Sir,
From
my
some
topic
sources.
for, yes, sir, I'm from Simpson.
Okay.
Good evening, everyone. I'm Dr. Veeresh from Sims Hospital. My topic for today's discussion is limitation and hazards of providing anesthesia in the MRICU and anesthetic management of a 6-month-old child with hydrocephalus scheduled for MRI. First, I will discuss about the anesthesia in MRICU. Anesthesia is a MRI is a non-invasive technology that produces three-dimensional detailed anatomical images. It is often used for disease detection, diagnosis, and treatment monitoring. And mechanism of working is MRI employs powerful magnets which produce a strong magnetic field that forces protons in the body to align with that field. When a radio frequency current is then pulsed through the patient, the protons are stimulated and spin out of equilibrium, straining against the pull of the magnetic field. And when the radio frequency field is turned off, the MRI sensors are able to detect the energy that is released from the realignment of the protons with the magnetic field. The MRI room is usually divided into zones. It is important for us to know about the zones so that safe anesthesia practice can be carried out. Zone 1 is the public area which is accessible to everyone. Zone 2 is used for patient preparation and holding area, and the ferromagnetic scanners are also present in this zone. Zone 3 consists of console and control room. Zone 4 consists of the MRI machine. First, preparation. An IV line is secured, preferably 18 gauge or 20 gauge. A clear line of sight of the patient and the monitor should be there. Anesthesia delivery equipment should be ready. Emergency equipment and drugs should be there. Complex airway management equipment should be there. All personnel entering zone 3 and 4 should be screened for ferromagnetic materials, foreign bodies, or implantable devices. An emergency communication system should be kept ready. An evacuation plan in place is if any emergency occurs should be there. First, general anesthesia and MRI. Anesthesia should be induced in a dedicated anesthetic room adjacent to the MRI scanner. The location of that room should be in such a way that patients can be easily and rapidly transferred and rapidly retrieved in an emergency condition. When an MRI safe anesthetic machine is not available, inhalation anesthetic can be administered from a machine in zone 3 to a waveguide. A waveguide is nothing but a copper line conduit that maintains the radio frequency isolation. It can be the anesthesia machine can be modified for use in a magnetic field by replacing their ferromagnetic components to less than 2% of the total weight. It can be made of stainless steel, brass, aluminum, and we can use aluminum cylinders for delivering gases. Vaporizers are affected little and they function properly in the magnetic field. Long Mapleson D circuits are used. Regarding ventilation, virtually it is impossible to visualize the patient's face and chest for adequacy of ventilation. Auscultation of lungs is also not possible. For this, we can assess the chest wall movements by using chest bellows, and the apnea alarm mattress are also available in some centers. In case of the ECG, usually the MRI machine will cause us superimposed potentials in the ST segment and T waves of leads 1, 2, V1 and V2. For this, we can use MRI safe ECGs in which electrodes are made of carbon graphite and we use fiber optic cables. Electrodes are placed in a narrow triangle on the patient's chest. For BP monitoring, we can use automated oscillometric BP monitoring methods. It is based on pneumatic principles. In case of a total intravenous anesthesia, MRI safe pumps can be used, and these pumps can be used freely in zone 4 itself. Or if MRI safe pumps is not available, the pumps can be placed in zone 3 and a waveguide can be used to connect the patient. In case of sedation, MRI safe anesthesia machine and airway management equipment should be kept ready. Hazards of giving anesthesia in MRI suit consist of the first one is static magnetic field. Items containing ferrous materials becomes dangerous projectiles. Implanted pacemakers, defibrillators, and other devices may be inactivated, reprogrammed, dislodged, or converted to an asynchronous mode by the magnetic field. For this, we can replace machines containing ferrous materials made of stainless steel or glass, search personal attire for pen, needles, vials, scissors, and other objects. The safe materials that can be used consist of nickel and stainless steel, titanium can be used. Install a test magnet outside the scanner room, and this test magnet is placed in zone 2. Radio frequency. Scanning room must be shielded from outside radio frequency interference. Any cable or leads can behave as an antenna for radio frequency and must be shielded because RF pulses may induce electrical eddy currents, causing short circuiting of the electrical equipment or causing burns in patients. For this, we can use aluminum foil to wrap cables, and small copper boxes can also be used. Lining the walls and windows with thin continuous sheets of copper can also prevent outside radio frequency signals. Acoustic noise. The switching of the gradient fields creates a loud acoustic noise, typically above the safe level of 85 decibels. This can potentially cause hearing loss, makes assessment of cardiac and respiratory function virtually impossible. And for this, permissible exposure to the noise level of this level should be limited to 2 hours per day. Staff and patients, either awake or anesthetized, must wear ear protection equipment. And time varying magnetic gradient field. This can induce electrical eddy currents in both biological and electrical learning. It can induce a current which is sufficient to stimulate the peripheral nerve cells and muscle cells, causing discomfort, seizures, or cause ventricular fibrillation itself. And nowadays, these available medical MRI scanners apply limits on this gradient field manipulation to avoid limb movements or ventricular fibrillation. The coils in cables and these should also be avoided. And in case of emergency conditions, like cardiopulmonary arrest, we have to immediately shift the patient from zone 4 to a safe resuscitation environment near the MRI scanner room, and we can initiate with this quench. A quench occurs when a superconducting magnet turns resistive and catastrophically releases all of the stored energy as heat, and this will result in boiling of the stored cryogenic gas. This gas has to be properly vented out. If not, this will result in MRI room hypoxia, because this gas will be entering the MRI room, and the amount of oxygen available for the anesthetist as well as the patient will be going down. And the entrance to zone 4 may not be possible due to the high pressure caused by the escaping gases. So proper evacuation plan has to be present, and pressure equalizing mechanisms, O2 sensors are also to be available in the MRI. My next topic is anesthetic management of 6-month-old child with hydrocephalus, scheduled for MRI. First, let me tell you in brief about hydrocephalus. Hydrocephalus is one of the most common pediatric and adult neurosurgical disorders. It is an abnormal increase in the amount of CSF, resulting in enlarged cerebral ventricles. This can be congenital or acquired. Causes: overproduction of CSF due to choroid plexus papilloma, blockage of the normal flow of CSF, which is caused by cysts, tumors, infection, hemorrhage, and congenital conditions like acute stenosis, Arnold Chiari malformation, etc. Signs and symptoms. Here I'm just going to mention the signs and symptoms which are seen in infants and newborn. Cranial enlarges at a rate which is more than the facial growth. Fontanelles are full and bulging. Poor head control will be there. Irritability and lethargy. Delayed milestones. Nausea and vomiting. Enlargement of the scalp veins. And McEwen sign, which is the cracked pot sound on focusing the over dilated ventricles. Sunsetting sign will also be observed in the neonates. Hyperactive reflexes, irregular respiration and apneic spells, and splaying of cranial sutures will also be present. Treatment consists of mainly surgical methods by placement of EPs, and the medical management is diuretic therapy using acetazolamide, furosemide, final tabs can also be done. Preoperative assessment. We have to ask for birth history of the infant, immunization history, family history, history of any allergies, previous medication histories, and fasting status. And we have to look for presence of any associated anomalies. And then we have to go for the systemic examination in CMS. First, we have to look for the level of consciousness of the infant, cranial nerve palsies, signs of raised intracranial pressure. In case of respiratory system, assessment of the airway, recurrent respiratory infections, hyposcoliosis, and we have to plan for respiratory support in postoperative period if required for the patient. And cardiovascular system, we have to look for any presence of congenital cardiac disease. In-prop monitoring, the following monitoring devices have to be present before inducing the patient: ECG, pulse oximeter, non-invasive blood pressure monitoring, capnometer, temperature monitor, arterial catheterization. Arterial catheterization is reserved for patients with uncontrolled intracranial pressure and hemodynamic instability. If required, we can use this. The preferred anesthesia technique in this procedure is general anesthesia. Induction. The aim of anesthetic induction is to avoid increase in intracranial pressure associated with hypercapnia, hypoxia, and changes in the
Hello. Hello. Hello.